All right, we will get started. Hello and welcome everyone to the Immune Deficiency Foundation's Webinar Wednesdays. Today's webinar is a SCID Compass Lunch and Learn on the basics of newborn screening presented by Ruth Ann Scheller, Amy Gaviglio, and Dr. May Baker. My name is Alyssa Huston, and I am the Director of Specialized Projects at the Immune Deficiency Foundation. And on behalf of all of us at IDF, I'd like to thank you for joining us this afternoon, or this morning, if you're on the West Coast, for this Lunch and Learn. We are excited to host this webinar for our IDF community. As you can see from our mission on your screen, IDF is dedicated to fostering a community empowered by education. We want you to remember that IDF is committed to our community, serving you as a trusted resource through the use of technology and innovation. We are here to give you the tools and information to become empowered and offer you our compassion, understanding, and support to emphasize that you are not alone on your journey. We are all in this together every step of the way, and it is because of our commitment that we will continue to provide you with forums and educational events. Today's Lunch and Learn is part of IDF's regular series of bite-sized programming that will provide diagnosis-specific information and support to the community wherever they may be. A brief disclaimer before we move on. Please remember that the information presented during this forum is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational forum or event. Many of you are tuning in today are doing so because you are an individual, parent, caregiver, or friend to someone with severe combined immunodeficiency or SCID. SCID Compass, an educational program of the Immune Deficiency Foundation, is designed to guide parents of infants diagnosed with SCID, people living with SCID, and the medical community through the journey of learning about this rare, life-threatening medical disorder and to help them find support to navigate the health challenges along the way. SCID Compass is supported by a grant through the Health Resources and Services Administration, or HRSA, which is an agency of the U.S. Department of Health and Human Services. SCID Compass was developed through a partnership between the Immune Deficiency Foundation, RTI International, and the Association of Public Health Laboratories, with support from Expecting Health and the SCID Angels for Life Foundation. To learn more about SCID and SCID Compass, please explore our website at www.scidcompass.org. The website is also available in Spanish, which you can find by navigating to our English site and clicking Espanol at the top of the navigation panel. I would now like to welcome Ruth Ann Scheller, Senior Specialist at the Association of Public Health Laboratories, Amy Gaviglio, Public Health and Genetics Contractor, and Dr. May Baker, Co-Director of the Newborn Screening Laboratory at the Wisconsin State Laboratory of Hygiene. Together, they will give us a look at the newborn screening process from the public health and laboratory perspective. Welcome.
Hello, everybody. It's such pleasure to be here and speaking with you. And this morning, when I tried to review my slides, prepare for this presentation, actually, I got very emotional. I always feel primary immunodeficiency community have a special place in my heart. I said that I'm talking if you see me, I don't know, you can see that. I really get emotional again. The reason is, I think some way my journey in the newborn screening has really throughout over the 15 some years now, and SCID is always with me. Yeah, because I was just finished my biochemical journalism fellowship, and I still recall the January 2007. I had a surgery. I was in the recovery in a hospital. I got a call from my director and asked me, because I was already confirmed I will finish fellowship and came back to newborn screening to continue my career path. And he asked me, do you want to take on a project, address the newborn screening for SCID? And think about that, let me know. I said, I don't need to think. I say yes. The reason is several years ago, I was at American Society of Human Genetics, and Dr. Jennifer Park, her trainee, I think it's Ki Chen, was presented the concept of newborn screening for SCID use the T-cell reception circuit. And I was getting so motivated. And afterwards, I was reading the paper and at that time, and it described 8 different genetic causes can cause SCID. So we now know it's a much more number, more than double. And it's just humble to think about science ever evolved. And also through the community, the Immunodeficiency Foundation and the models. And I get so many opportunities to interact with families. And I'm sure some audience maybe we met at some conference. But anyway, I can go on and on. But I just want to have this opportunity to express my gratitude to all of you. So today, indeed, we talk about immunodeficiency, but I want people bear with me, walk with me through a public health newborn screening. The laboratory, what do we do? So first, I want to say, we do more than SCID, severe combined immunodeficiency. So laboratory, as a laboratory actual program, we have 2 parts. One is we call a point of care screening. So here we list hearing and also critical congenital heart condition. But my emphasis today is talk about through dry blood spots, we identify 47 different conditions in our laboratory. So this is give you a general sense. This is what a newborn screening laboratory whole operation looks like. You know, the disease condition and different condition, we use a different technology. I will, over the course, talk a little bit about SCID and just give you a general sense. So not just a testing. We constantly evaluate how well we do. So from this structure, and each study may be a little bit different, but the concept is here. So we, for each different the specialties, we have a physician scientist, we have a parents advocacy group, and we have a midwives, we have public health officials, and together we want to continue to evaluate how we do, how we improve, and trying to make things better. And also in Wisconsin, at least, we have a called Wisconsin Secretary Advisory Committee. It's kind of echo to federal, the structure. And this committee specifically to address added new condition. Sometimes we have to evaluate certain condition may be not as suitable for newborn screening. We may remove the condition. Over the time, we did take a couple conditions out of the panel. So this is maybe not too strange to you, these cards. So we really ask a lot of information and from these cards. So the dry blood spots is the matrix we call for the testing. Think about that. For these 5 circles, we will detect 47 different disorders. And I would think it's quite amazing. And I often have medical students and pediatric residents, and they always come in the laboratory and will left say, wow. The reason is that you have the visual, you see the laboratory, and in this relatively not so big space, you can process thousands samples, and every day, every month, every year. And the important is I want to address here is the accuracy information is terribly important. So hopefully you can take the message to your neighbors, your relatives, and especially the expecting parents. And it's because a certain information it's help us to interpret testing result. And because of the time limitation, I don't get the details. I think this general concept, I hope you with me. And I always say garbage in, garbage out, right? We want to have things started correctly. So in that sense, you can help. Come to newborn screening testing, and it's just I said beyond the spot. It really is the whole system. I think other speakers will talk even more, and kind of appears a little bit redundant, but I don't think so. I feel like emphasizes is needed, and newborn screening really is a system. So we need everybody help to get the best outcome. Start with in the pregnancy, and we be sure the family and expect parents really understand what newborn screening about, what you can do, and that's part. And we need we call the submitter, which is a birthing hospital and midwives, and give us timely, satisfactory specimen. And also we be sure the transportation take as less time as possible and get a laboratory testing. And after the laboratory testing, we have a certain, we call a follow-up. And Amy will get more detail on this part. So laboratory testing, again, I'm not going to get bored to talk more details, but I think I want you take a home message is there's a lot going on, and indeed for the quality insurance. So we want to make sure what we do and have the best accuracy and proficiency to do that. And so we have a lot of regulatory and the policy piece in that. So give you the sense is indeed it takes a lot to do the best testing and quality testing for your children. So come to, I think, have a direct relationship with you is the newborn screening testing results. So I cannot emphasize enough. I do believe my colleagues will talk about this too. Newborn screening is a risk assessment. Different than somebody sick, getting in the hospital, trying to find the answer. But here is, we do a testing in the whole population. It's really identify the children with some high risk. The high risk, the next step is to do further testing we call confirmatory. So in general, we try not to potentially miss some cases. See, this everything's relative, right? So we kind of set the threshold to allow the certain false positives. Even that, no system is perfect because each kid can have different scenario. So we emphasize the risk assessment. So the things that we have a more confident, we say screening positive. We ask going next stage to the confirmatory testing. For some testing, we have a less confident. We said, let's do another newborn screening, verify what we see, and go from there. So we call the screening possible positive. A certain part we do in the situation, we can say for sure. For example, for the screening for SCID, so we get a specimen, and you do have a low counts of T cell receptor exertion circle, but because the testing is based on the DNA, if the DNA, the extraction or for whatever reason didn't give you good quality or good quantity, in that scenario, we don't feel quite comfortable saying that maybe it's just because you have potentially have high risk for SCID. And then in this situation, we said, result really is, we call it inconclusive. We take another specimen to take a look. So that's the situation we encounter every day in the laboratory. So if we use a marker, as again, I use a SCID example, T-cell receptor excision circle, if we set a threshold in the level and your children have the level cross that threshold, we said, very, very low risk for these disorders, we will say screening negative. But important things, remember, if any system suggests, and regardless of screening results, you should take a thorough investigation. So it's why I hope I spend time and I hope I can convince you. And if not yet, I'm sure Amy will try to convince you later. So, and Wisconsin, and I feel very proud and very fortunately in terms come to screening for SCID, we are really is the first one in the whole world, and the whole process has been very rewarding. So we started to screening in 2008, and this is over 11 years data. We are relatively small compared with Texas, compared with California or New York. So given that a long time, we are not quite 1 million babies yet, but we have identified 17 SCID, and I put SCID/severe T lymphopenias case. The reason I say so is the marker we use, the T-cell receptor excision circle, really is the surrogate marker to talk about it. To represent the T-cell development in the thymus. So this T lymphopenias can happen in SCID, but also can have other cause for that. So keep this in mind. I use a severe term is indicate, even it's not a typical SCID, but they perhaps need a bone marrow transplant, or also could be a thymus transplant in a situation like DiGeorge. So I think that's the way. And another thing that I want to say is, and everybody in primary immunodeficient community should be so proud for a couple of reasons. First, the SCID is the first ever disorders, and the program utilizes DNA as the first tier testing. So you paved the way. So now we can add other condition is a spinal muscular atrophy. I use the word easily because your system in place, and for our experience, you're adding on really in terms of reagent cost is pennies, able to do that. Of course, we talk about newborn screening system, other things have to be into the play, but the technology piece and instrumentation piece really set the good stage. So I'm very pleased to be part of the journey and working with you. So I think this is my last slide. Thank you very much.
Perfect. Thank you so much, May, for starting us off. It's always an honor to be able to speak with you on a topic that I definitely know means so much to you, and for what you have made, so much impact. Thank you. So in the previous presentation, May discussed the overall kind of program operations and really focus on the part that I think many people first think of when they think about newborn screening, which is that testing piece. That kind of analytical piece. And for my portion, we're going to focus a bit more on the kind of other three components. So the pre and post testing parts, and then I'll also touch on the education and communication needs within the newborn screening program. And I think there was some animation on this slide, Ruth Ann, so you may need to click through to get to the next one. Perfect, thank you. So Dr. Baker alluded to this as well, but in terms of education, one of the most important parts that we really need to understand is the difference between a screening test and a diagnostic test. And this slide illustrates kind of the three main differences that I think are really important when we think about newborn screening. So the first is that, in terms of the population that it's offered to. So in a screening paradigm, you're really looking at the population that does not yet have symptoms of disease, but for which early detection can be really important. If we contrast that to the diagnostic test, typically that's going to be offered to someone who already has symptoms or has actually already had a positive screening test that suggests they may need to have further testing. In terms of the results that come out of the two, Dr. Baker was right. I was going to talk about this as well because it is so important, but that the result is really an estimated level of risk. It's not saying, yes, you are affected or no, you are not affected. It's just saying you're either at higher risk or lower risk. Whereas, as we all probably know, a diagnostic test tends to give you a more definitive kind of answer, an actual definitive diagnosis. The final one I wanted to point out was a little bit around what we would call test metrics. So in a screening test, we are really looking to kind of have what we call high sensitivity, which essentially means we don't want to miss someone who might be at high risk. And so in order to do that, we have to cast our net a little bit wider, which means that we probably are going to get false positive results. And there's some acceptance around, the fact that in screening, you are going to have false positive results. That's different from a diagnostic test where they're really focused on high specificity. So they're really wanting to make sure that if they have a positive, result, that it is truly, what they're seeing. So you see a lot more precision and accuracy in a diagnostic test. So this schematic illustrates a little bit more what we discussed kind of on the previous slide. So if we look at newborn screening, it's applied to a kind of seemingly healthy or asymptomatic population of newborns. And then the screening test, so you can kind of see the blood spot card that Dr. Baker showed, is used to kind of weed out those that are at higher risk of having the disease and lets those that are lower risk kind of pass through or get screened through to kind of a different population. So the newborns identified at higher risk then must complete further testing, which again, we call diagnostic testing or confirmatory testing. And this helps us determine whether the child is truly affected, so a true positive result, or whether the child is actually unaffected, so a false positive result. But it's also important for us to not forget about those infants who passed through the screen. While the vast majority of those will truly be unaffected, so what we call true negative results, because it is screening, there is the risk that some infants may actually still be affected and have been kind of missed by the screen, or what we call a false negative result. Right. So it's also important for us to note some key points about newborn screening programs here. So first, they are public health programs. And that really means that they need to balance individual and public benefits and harms. This also really means that coordination among a really wide range of stakeholders must occur for the program to be successful. Newborn screening programs are also state-based, so each state administers and chooses how to run their own program, and this also, of course, means that differences do exist between programs from state to state. Newborn screening is considered an opt-out program as well. So what this means is that, because of the relatively low risk of newborn screening, it's a simple kind of heel stick, combined with the potential benefit of early diagnosis and treatment, the default is for newborn screening to happen. Only if parents do not wish for newborn screening to happen, they must opt out or refuse to have it completed. So again, default is for it to occur. And then finally, a hallmark of newborn screening is the focus on treatable conditions. So in order for a disease to be appropriate for newborn screening, appropriate for population health screening, there must be an effective treatment available. So with that background and information in mind, let's kind of take a closer look at what the process looks like. And we'll start in that kind of pre-analytical phase, which largely happens within the birth facilities. So here we can see 4 steps. So to begin, we really ask that families be provided education about screening before the sample is collected. Ideally, this would include the prenatal period, though I think that happens kind of sporadically throughout the country. After that education and kind of assuming that the family doesn't opt out, the blood spots are then collected. Again, this is done by a heel stick, typically done between 24 and 48 hours of life. These specimens are dried horizontally on that filter paper card that Dr. Baker showed, and that just kind of helps it set. And then those can be sent to the state screening program, the laboratory. Again, we want this to happen pretty quickly because some of our conditions can present very quickly. So we ask this to be done within 24 hours of collection. So moving along in the process, and I won't touch on this too much since May covered this so nicely, but very quickly upon receipt within the public health laboratory, we kind of accession in those specimens. We enter the demographic information so we can make sure that we know who we're testing. And then we actually do the testing, which again, as Dr. Baker mentioned, involves looking at those T-cell receptor excision circles. After testing is done, results are entered. We verify them, make sure that there were no mistakes made before releasing them, and then they are kind of sent off. And I won't cover this in too much detail either. Again, Dr. Baker discussed the differences of the types of results that we can have. But I do want to focus a little bit on what we think about in particular with kind of SCID or other T-cell lymphopenias. So we do, most often see what we call normal or negative results. And again, this does just mean that the child is at low risk. So one of the things that we really encourage is that for providers and clinicians to, if they're concerned that this child may have SCID, may have a T-cell lymphopenia, reminding them that it was just a screen and that they should still work that child up regardless of what the newborn screening results were. And then if we look at kind of abnormal or positive, in those cases, we typically then send those results out to immunology or infectious disease specialists so that we can get further evaluation. Those are going to be our high risk individuals, so that last row. In the middle are two categories where for SCID in particular, they can be used. And typically this just means we want to get another look at a newborn screen. We're not really sure where they fall within that low to high spectrum. And so we just want to take another look and see if we can kind of get a better sense of what might be going on. So this would be those cases where you may get a call from the primary care provider asking for another newborn screening result. So once the result is kind of generated, we enter what we call the post-analytical or follow-up phase of newborn screening. And so this is really where we try to call the results out as quickly as possible. For SCID, we try to call them out and have them ready to go in less than 7 days after birth. So we're really trying to push this along as quickly as possible. If the results are normal or those low risk results, those are typically just provided back to the birth facility or whomever collected the specimen. And we ask them to be sent on to the primary care provider. If we do have positive results, we take a bit more active approach. Those we typically call out both to primary care providers and specialists, making sure they know that we have this result, that the family needs to be notified, and that we need to kind of move this follow-up clinical process along. And typically we ask for that to be done, kind of as soon as possible, so that we can get a diagnosis and start that treatment process as quickly as possible. So to delve a little bit deeper, I kind of want to focus a little bit more on this clinical follow-up piece, again, really focusing on how this applies to SCID and the other T-cell lymphopenias. So if we start with the family, certainly we want these results communicated in as knowledgeable and compassionate as a way as possible. Many programs provide written fact sheets that can be provided to the family. So really trying to give them information both orally visually and verbally. And one thing that can help, obviously this is often giving unexpected and high anxiety news. And so, being able to have the provider or a genetic counselor or a nurse kind of follow up with the family after that notification has been shown really to kind of help just ease anxiety and ensure knowledge is retained. In terms of the diagnostic testing that is ordered, I'm not going to go into these details, but they are here. There is kind of a host of different labs that may be drawn in order to get a better idea of kind of if this is truly kind of a typical SCID situation, or if this is potentially an other T-cell lymphopenia. In addition to kind of what we call more biochemical lab results, if those look abnormal as well, we may go on to genetics. And as Dr. Baker mentioned, now we know there are over 30 genes that may cause SCID, and so this genetic analysis can really help further understand what's going on. And so to wrap up my section, I did want to end with some kind of existing ethical considerations still facing newborn screening programs. The first really centers around that education and communication piece. So it may not surprise you to hear, but many parents still really don't hear or know about newborn screening prior to collection of that newborn screening specimen, which can really make giving positive results very difficult because they don't even remember that test happening. And in terms of giving out those positive results, parents have certainly expressed the need, as I mentioned earlier, for more informed and compassionate notification of those positive results. The second piece is certainly pertinent to SCID newborn screening, in that we often pick up things that we might not have been focusing on. And SCID, again, is just a great example of this. Our focus is truly kind of that typical SCID phenotype, but because of the way we're screening, we certainly pick up a lot of other things that really are beneficial to pick up, but really thinking about how we communicate that, how we follow up with those, what do we do when we pick up something we don't really know much about, or if there isn't treatment. So this certainly remains an ongoing issue for newborn screening programs. And finally, if we kind of go again along that spectrum and go into that follow-up space, there are a number of existing issues around accessibility of treatment, which is different than availability of treatment, equity, as well as care coordination. So towards the beginning, I mentioned that multiple stakeholders really need to play a role in the success of newborn screening. And I hope this slide illustrates this large web. And so now I am pleased to be able to pass the presentation on to one of these key players, the Association of Public Health Labs, and Ruth Ann Schiller. The mic is yours.
Thanks so much, Amy and May. I love the slide. Beautiful visual. Great. So hi, everybody. My name is Ruth Ann Scheller, and I've had the honor of working with newborn screening programs and my amazing colleagues on this call for the past 5 or so years now through my role at the Association of Public Health Laboratories. We're also known as APHL. Both Amy and May provided a really nice overview of the newborn screening system. And today I'll be spending my portion of the call sharing some more information about APHL's role in supporting newborn screening programs. And then I want to touch on SCID newborn screening experience in the United States. So given a nice history of that, highlighting some of the hurdles, successes, and ongoing challenges and opportunities that newborn screening programs continue to face. So I really liked Amy's slide, but I also wanted to start with this visual just to give you all a sense of where APHL and New Steps fall in. So you'll see on this slide that there's many stakeholders and partners involved in the newborn screening system. There's the public health decision makers and legislators. So some newborn screening programs follow National Recommended Uniform Screening Panel, which is also known as the RUSP, when they're considering bringing on a new disorder. And then some consider the RUSP as one factor in decision making. And then others take a more active and state-centered role when they're deciding whether to bring on a new disorder or not. And then there's specialists, families, and healthcare providers who often provide valuable input to national and state level advisory groups on different aspects to consider when adding new disorders. And then there's the newborn screening programs who work with these stakeholders while considering bringing on a new disorder. And once they are ready, they are the ones that are responsible for acquiring the appropriate screening equipment, training staff on how to use this equipment, and working with specialists to report screening results. So our goal at APHL is to strengthen the role of public health laboratories in population screening and to design strategies to address the changes in the field of newborn screening. Newborn screening is constantly evolving. It's a very exciting field, and states are constantly responding and adapting to demands from legislators, advocates, and the National Advisory Committee. So our goal at APHL is to organize and help facilitate a number of committees, work groups, task forces, and national meetings that bring together the newborn screening programs from across the nation and allow them a platform to share best practices. As states are bringing on more and more disorders, and some of these disorders have later onsets of symptoms, we're excited to embark on more long-term follow-up activities as well. So a component of APHL is our New Steps program, which stands for the Newborn Screening Technical Assistance and Evaluation Program. And our goal at New Steps is to provide tools to state newborn screening systems so that they can adequately evaluate, analyze, and benchmark the performance of their tests and get a sense of the quality of their newborn screening programs. So with the support of our funders at the Health Resources and Services Administration, also known as HRSA, and our wonderful partners at the Immune Deficiency Foundation, we're able to continue to provide direct funding and technical assistance to support newborn screening programs throughout their SCID newborn screening implementation experiences. All right, so let's take a look at the SCID newborn screening journey. And I first want to begin with 2008. Wisconsin and Massachusetts were among the earliest adopters of SCID newborn screening, offering SCID prior to when it was added to the recommended uniform screening panel. Following the addition of SCID to this national recommended panel, California and New York implemented SCID newborn screening, as well as the Navajo Nation in Arizona. As time progressed, additional states began to onboard SCID screening. I'll show the progression in these slides. And then in 2014, APHL was awarded our first SCID cooperative agreement, which allowed us to provide financial support to 11 newborn screening programs that were interested in onboarding SCID at this time. So you'll see those noted with the gray circles. And at this time in 2014, a little less than half of the states were offering SCID screening. In 2015, more than half of states were screening for SCID. And then by 2016, more than 75% of newborns were screening for SCID, or programs were screening for SCID. Please also note that these maps do not include Puerto Rico, DC, or Guam, but they have been included in all the denominators of the percentages that I'm sharing with you. And DC and Guam began screening in 2014, and Puerto Rico began screening for SCID in 2015. In 2017, we had 94% of newborns screened for SCID. It looks like one of my slides is missing, but it's the most important slide. In 2018, we celebrated all 53 newborn screening programs offering SCID newborn screening. So the whole map is orange now, and we're very, very excited about that. So as you can see, it did take several years for states to offer SCID newborn screening, and that's because each state has unique challenges. They have unique legislation, advisory committees, advocacy groups, fees, equipment, and personnel that all play a role in onboarding new disorders. So on this slide, I'll touch on some of the challenges and opportunities. Many of the barriers that states face were similar to the barriers that they face when bringing on new disorders to their state panels. And this included obtaining state legislative mandates, acquiring fees to support bringing on a new disorder. However, as May mentioned before, and Amy also mentioned, SCID did have some unique challenges. And that SCID was the first newborn screening disorder to utilize molecular technology as a first-tier screening test. And so that required bringing on not only new instrumentation, but also making sure that programs had staff that were trained on this instrumentation. So acquiring this new instrumentation posed several challenges for newborn screening programs. They needed to seek funding to support purchasing new equipment. Some programs also didn't necessarily have adequate laboratory space at the time, so they had to kind of get creative with finding a space for this molecular technology. And then they also needed to make sure that all staff were trained on performing this testing. While some states chose to use an FDA-approved methodology, other programs took some time developing their own laboratory tests. So there were some differences in the methodologies that programs choose to explore. And additionally, there were new challenges presented while interpreting molecular results for follow-up. So overall, this new technology, coupled with limitations in funding, laboratory space, and technical expertise, proved to be challenging. SCID implementation involved continuous changes to each program, but it also revealed areas for growth and collaboration. In fact, programs were able to convene multidisciplinary teams, and they were able to support one another by sharing protocols, advice, and expertise. One of our programs and program directors in New England shared that SCID implementation was one of the best examples of newborn screening programs supporting each other. People shared widely different protocols and advice, and there was a lot of communication. So I wanted to wrap up with some current opportunities that are available to newborn screening programs through our partnership with the IDF and with support of funding through HRSA. We're so grateful to be able to continue to support newborn screening programs, both with technical assistance and funding. We recently issued a funding announcement to support newborn screening programs that were interested in updating their instruments or exploring new methodologies such as next generation sequencing. As May mentioned before, some programs are going to be using SCID methodologies to also test for another disorder, spinal muscular atrophy. So we're helping provide funding so that they're able to update their equipment so that they're able to do that. And then other programs have been seeking funding to be able to update their databases so that they can make sure that they are communicating with providers and specialists in as efficient of a way as possible. We're also really grateful to be in the very early stages of partnering with the University of Wisconsin to launch a SCID screening quality improvement project for screening premature infants. What we've been witnessing across newborn screening programs is that there is a disproportionately high number of false positive SCID results among premature infants. So our hope is to collect data from multiple states, get a sense of their different screening methodologies and algorithms. And our hope is that we can take a look at this data and ultimately provide a recommendation that will ultimately reduce any unnecessary follow-up activities associated with screening this particular population. So we're very excited about that. And with that, thank you all so much for tuning in today. If you have any specific questions about APHL or just the national landscape of SCID newborn screening, please feel free to send them our way.
Thank you so much, Ruth Ann and Amy and Dr. Baker. I certainly learned a lot about newborn screening. It's a wonderful public health service that not a lot of people know about. So we do have some time for questions from the audience. So if you have a question for Ruth Ann, for Amy, for Dr. Baker, please use the question and answer box that you should be able to see on your Zoom panel, and we will read them out loud. I do have one question for our presenters. It was mentioned that parents can opt out of newborn screening, even though many of them don't realize that it is happening. Why would a parent want to opt out when it can provide them with some much needed information and early diagnosis?
I can start, but certainly Mayor Ruth Ann, please, as always, jump in. I think that can be a hard question for us to answer sometimes, because in many cases we don't ask that question on the form why you're opting out. But I would say anecdotally and from observation, it usually is. Usually is for one of a couple of reasons. So we tend to see families opt out who also opt out of other public health type initiatives, immunizations, the vitamin K shots, those types of things. So it's not necessarily limited to newborn screening. It's more of a kind of just a personal belief around all of that type of kind of intervention. I think the second reason that has come out in some cases is these are public health programs that are run by a government entity. And so sometimes that fear of the government can play a role as well. And I think states have tried to offset that a bit by trying to allow parents to ask for the samples back after, or the ability to destroy them after, because ultimately our primary goal is always to do the screening. Kind of what happens after in terms of the storage of the spots is after. So if we can find a way to ameliorate those concerns while still getting them screened, I think we always try to do that. Ruth Ann or May, I don't know if you have anything to add. It's a great question.
Yeah, couple things adding on based on what Amy already said. I think the question is why you don't ask the reasons. I think for us, we made it very clear. We want parents to feel safe, feel not be, we want to respectful. We allow you because for whatever reasons, and we no question to ask. The challenging part is I want to be sure they're being fully informed, correctly informed, and they make a decision whatever we respect. So when I on the phone and when, Boarding Hospital asked, I said, what I do, I said, be sure to tell parents how important for the for the baby's health. I think it's important. As Amy alluded, people have different mindset in terms of government getting my kid's DNA or whatever that they believe. So when I have opportunities, I always emphasize newborn screening first and foremost is clinical care for the baby's health. And we do need to monitor, and when the purpose is the continued quality improvement. We want to do better. So I think most parents are very reasonable when they have understand this and they have a better, say, okay, now I get it. And I think another thing, so we are adamant, and I hope I have your support, is we don't return the residual drug spots because technically this is a medical device. But we do accommodate a parent's wish, said when my specimen is down, I want to enjoy it. And we basically said, just have a written request. We accommodate that. So I think you can tell, as Amy said, not only we say so, we really do so to put the baby's health at the top. As long as we can accomplish this mission, otherwise we can discuss, we can be flexible. So we really want to accommodate to get it because we strongly believe it's the best get the baby started healthy babies from the beginning.
Yeah. Thank you, Dr. Baker. We have a parent who is wondering why states differ so much with how long they retain the newborn screening cards.
You guys are just too smart for me, I think. That's very a good and important question, because the newborn screening, and recently, because you sense about, we have some federal committees and recommendations, but it's a state program. Each state have their own and the way to look at things. And I can give you some example. And interestingly, you ask a question, because our state is in a discussion in terms of our screening, the keep the specimen, the length. And at least our state, the philosophy, again, patient care. So we are currently screening. I mean, I think if you look at the whole state, and I did some research, and for some months to forever. And I think, and actually so many in the between, and the justification, what I understand, actually I did a little bit quick survey too. The understanding is somebody say, hey, that is the medical records. So just like any other medical records, we're going to keep it for 21 years. So that's one thing. And I think this is kind of, and some states even say 21 plus 2, because you allowed this, the baby become adults that can make a decision. And in the between this, and like, for example, let's say 5 years. And why 5? And the rationale is 5 years allowed you say you assess a certain disease like cystic fibrosis. If you sure have a false negative, and you have sense, go back and check the original spots. And the recently get a lot of attention is a congenital CMV infection, because at the birth, that's the only opportunity you can retain the specimen due to congenital CMV infection. Actually, this community actually familiar with that. If you think about a bubble boy back then, it's because if a healthy individuals and have a CMV infection, you're fine. But if you're immunity compromised, you could have a problem. And the congenital CMV, could cause issues, especially after birth, with about a 5 years frame, but it's not absolute. You could have a sensory hearing loss. Then at the time, you want to know is potentially caused by congenital CMV, and you need a specimen. But you have to go back newborn screening, because it's a very common infection, and a lot of people walk around have this. But again, as I said, if you have good immune system, you're okay. So I hope I try to answer the question, but each state have different scenario.
Yeah, May I think when I get that question, I kind of try to say, and I see that one of the questions was, could it also be due to storage space issues? And I do think that actually does play a role sometimes. It ideally, for them to continue to be useful, they do need to be stored a certain way. Obviously, you don't want them to be really warm. They should have what we call desiccant to keep them from getting too humid, kind of keep them dry. And over time, that storage can be astronomical. So I do think in some ways that plays a role, but it also, I usually think of like 4 different ways or 4 different reasons why the blood spots are retained. One is for, just kind of that ongoing quality control and making sure we're doing a good job. Everyone wants to do that, but you don't need to restore the specimens for that long to be able to do that. The other is for what May mentioned. You can do further health-related testing where the blood spots are really the ideal source to determine if there was an issue at birth. If your program isn't interested in offering that, or doesn't have the ability to offer that, then you may not keep them as long. They can also be used for public health research. So as Alyssa mentioned, not many families do opt out of newborn screening. So it ends up being this like beautiful birth cohort sample where we can learn a lot from. But again, if your program isn't set up to be able to do that, you may choose not to store them as long. And then finally, like May said, that they're very helpful for if you do miss a case to go back and try to figure out why. And so I think that's where you start to see those 5 years, those kind of in between times. So I think it really depends on kind of what your intention is going to be in using those afterwards. I think that helps dictate the time frame.
Thank you so much, Amy, Ruthann, and Dr. Baker. We do just have 1 minute left in our webinar today, and I want to end with just a statement from a parent who says that this is not a question, but just a huge thank you to all of you that you do to advance newborn screening. This service played a vital role in saving my son's life, and I am forever grateful. So I think that's a really great point to end on. Not many people know about newborn screening and the wonderful public health service that it is, but it's certainly something that makes a huge impact on many lives. So again, thank you to our presenters, Ruthann Scheller, Amy Gaviglio, and Dr. May Baker. If you have other questions related to newborn screening or SCID, you are always welcome to direct them to Ask IDF, and we can relay your question to various subject matter experts and get back to you. You can go to primaryimmune.org/ask-IDF to submit a question. Just a few other things before we wrap up and sign off. Please remember to take advantage of all the resources that IDF has to offer. This includes our newly updated IDF Patient and Family Handbook for Primary Immunodeficiency Diseases, the 6th edition, which also includes an updated chapter on SCID as well as a chapter on newborn screening. The handbook is easy to access and available online for download at the link below. There are also a number of SCID-specific resources that are available through the SCID Compass program. You can also access those at the link below. And I would just like to say a huge thank you again to our presenters, as well as all of you who tuned in today for this Lunch and Learn. I hope you'll join us next month, January in 2021, for our Lunch and Learn on Genetic Counseling for SCID, presented by Morgan Similek at the National Institute of Health. Registration is now open, and you can find that on primaryimmune.org/events. So thank you all for tuning in today, and I hope you have a great rest of your day and your week. And if you're on the East Coast, I hope you enjoy all of the snow, and take care.